So thank you again for taking time this afternoon to learn a little bit more about the Support After First Responder Suicide, or SAFeRS study, as we release our first round of results from this particular study for public access. I am going to be sharing my screen and going through a short presentation with you all, and then we will be opening the floor for questions through the Q&A section of the webinar. So you are welcome to, throughout the course of the presentation, type your questions into the Q&A section of the webinar portal. I do encourage you to actively be using the Q&A section throughout the course of the presentation, because you also have the option to upvote other questions that people have asked. So questions that people have a lot of interest in hearing the answer to, we'll put some emphasis on making sure that those questions get answered. You'll also be able to use the chat function. You'll also have noticed the lovely Hannah Bourne is joining us today. So in the Q&A section, if needed, we'll also have the opportunity for people to raise their hands and share and ask questions that way as well. So I'm just going to share the presentation screen with you all. Okay, so welcome to the public release briefing for the Support After First Responder Suicide study. This study was funded by the Hospital Research Foundation Group, who underpins Military and Emergency Services Health Australia. Before we go too far, we do want to begin with an acknowledgement of country. So the Hospital Research Foundation Group acknowledges the traditional owners of the country throughout Australia, and we commit to building a brighter future together on the land that we all call home. The Hospital Research Foundation Group offices are situated on the traditional lands of the Kaurna people, the Whadjuk Noongar and Ngunnawal and Ngurami peoples, and we recognise and respect their continuing connections to the lands, waters and communities. We'd also like to do a brief acknowledgement of service, so acknowledging the years and lives of people who have served Australia as members of our Defence Force and our emergency services, and all of their families, past and present. We also want to do an acknowledgement of lived experience. So we honour all of those with lived or living experience of suicide, including people who are bereaved, carers and supporters, and those who have experienced suicidal thoughts or survived an attempt, and those who are no longer with us today. This study was underpinned by a lived experience advisory committee, without whom we would not have been able to do this work. So it is a core and essential part of the work that we're doing to have that lived experience at every single stage. Finally, before we get too far, we just want to acknowledge that the content of this briefing does address a sensitive topic, and it might be distressing for those who are present. So if this briefing raises any concerns for you, please reach out to a MESHA staff member who is present via the chat, or we recommend that you contact Lifeline and Beyond Blue. Both of their numbers are on the screen now. There is a list of emergency services specific support services that are on the MESHA website if you would like to head there and have a look at the different services that you could access should you find that that is something that you would like to do. To start with, I would just like to acknowledge all of the people who contributed to this work. So while I am Dr. Henry Bowen and I am the Research and Training Lead for the Hospital Research Foundation Group MESHA, and I'm presenting this work to you today, there were a lot of people who gave their time and their energy to this work. So starting with our National Advisory Committee on Military and Emergency Services postvention, many of whom are present today to see this presentation, so thank you for attending. Also the research team who put so many hours into designing this study and conducting all of the interviews, with the support of the support team who sits behind them, and also the participants who gave their time to share their experiences and their openness with so much transparency. What we'll be presenting today is the high-level findings of the SAFeRS study with the actionable steps that organisations and leadership can be taking. But it is our first round of analysis. We have hundreds of hours of interview data, and so there will be a lot more to come from this piece of work. But we wanted to start with what we thought could be the most actionable results for organisations and leadership as soon as we had them available. For today, we're going to be talking about postvention. So postvention is prevention. So we know that there are the concepts of postvention being the actions taken after a suicide death overlap a lot with prevention. But for the purposes of the conversation we're having today, we are only going to be talking about postvention in the context of what happens after a death, not an attempt, which can sometimes include postvention. So just to set the scene, the official count of individuals who have passed by suicide who have a background as a first responder or an emergency service member was first given to us by the National Coronial Information System. And that estimated that over a 15-year period, we were looking at about 197 known suicides. However, not long after that report was released, there was another report released which said that if you added 5 years to that investigation and only looked at police officers, we were looking at 103 serving officers who had died by suicide, which was an increase over the last 2 decades. What this told us is that there is some inconsistency in the numbers. So being able to understand the impact of this, of suicide deaths of first responders was quite difficult to do because we're not entirely sure of how many first responders are dying by suicide. And that makes it really difficult to identify and support those who might need that support. It's also very important because these are the statistics, but behind every statistic, there's a family, a crew, a station, and a community. And so we need to know, how do we make sure that those individuals are being supported when we're not even entirely sure who they are? We started this work by doing a bit of a background look at the work that was available or what other people had done. And so we went and had a look at what is the published research? What are the resources? Are there any guidelines to support organisations in the event of a first responder dying by suicide? And what we found is that there wasn't any published research that had been done in Australia, that there was no guidelines or resources or training that was specific to postvention when it came to military or emergency services, and that there was no services that were available, so no service providers that were specifically available to offer support for families and peers if a first responder died by suicide. So that's how this study came to be. We thought, before we go out wanting to help, we need to better understand what people need. So the Support After First Responder Suicide study aimed to understand what were the experiences and the perceptions of co-workers who had lost a loved one to suicide, of the family members who had lost a loved one to suicide when they had been an emergency services worker, and what is it that they said they actually needed after that death. So we ran this study over a 9-month period. We used a recruitment methodology called snowballing, which is where people came and accessed the study and then they passed on the details of that study to others. So people could share it via email, social media, physical posters, word of mouth. The recruitment was available throughout the entire country, but we didn't have anyone respond from the ACT. We had a 2-stage collection, so people had the option to do a survey, an interview, or both. Most people did both the survey and the interview, but for some, they chose only to do the survey. Coming in now to the results, We're going to go through some of the points of difference that were identified between a suicide death of a first responder and a suicide death of a civilian. And one of the biggest things we heard in the interviews was around the fact that the first 48 hours following a suicide death of a first responder is different. And predominantly, this is because who responds to a suicide death? Well, it's first responders. So the likelihood of a first responder going to a job, responding to an incident scene, and having known the person that they are responding to is very high. Even when steps are taken to try and create some separation, it's not always possible. And it doesn't necessarily mean that they have to have worn the same uniform. It's not uncommon to have had paramedics go to call-outs for police officers, having worked with those individuals before. And if they're not going to the scene, it might be the case that they are then the one having to respond to the family. So we did hear a lot from people who talked about the fact that they were either showing up on scene and then identifying the person there as someone that they had worked with, or they knew that going into it, but were still quite caught off guard when they got there and realized this is someone that I have worked with before. Another point of difference that came up in the interviews was around notification. A big thing was that there was no standardized process across agencies for notification. So the most common process was that an all-staff email is sent out, but what was in that email and the timing of that email was differed across different states and territories, but also differed from agency to agency. What we heard a lot of is people finding out that a colleague had died by suicide via word of mouth, often via social media or through text message channels. This was especially true if it was a retired member of service. So someone who had since left the service and didn't have access to official channels anymore, was often finding out through social media. The changing of the Facebook icon was the most common way that people were finding out via social media. What we heard a lot about was the fact that language really mattered in these notifications and in these communications, because there was often the avoiding of the use of the word suicide. Now, there are some real legal and practical factors that go into why you wouldn't necessarily use the word suicide in an email notifying co-workers. It's not a suicide until a coroner declares it a suicide. It's always a suspected suicide. Perhaps family have requested that. But when people didn't get that kind of clarity, it kind of led to a sense of sweeping things under the rug. There was a real emphasis on the fact that if someone were to die in, say, a car accident or because of a medical episode, that is said during the email. So saying nothing was often perceived as telling everyone it had been a suicide death. It was also seen as very generic. The emails seemed to have blanket statements that said, contact our local EAP. And for some people, it felt almost insulting to receive that email because they felt like it lacked a personal touch and there was no genuine interest or concern. What we heard a lot is from people who wanted to feel connected and supported by their leadership in a personal way. There were people who commented on how they had lost several of their colleagues to suicide over a 6-month period, but every time the response was very similar. Overwhelmingly, the need for acknowledgement for the person who was grieving, for the person who died and the death itself, and a validation of that grief that was experienced was heard from nearly every participant. Feeling cared about and validated by leadership and peers is really crucial for those who are recovering after a suicide death. And it really helped people feel like there was services available they could access. It made them more accessible. There were a couple of comparison points that came up in the findings of this study. There was a lot of times where people talked about employee assistance programs and then also talked about peer support and chaplaincy. The general response was that EAP programs seemed a little bit generic, and while they were useful, they weren't fit for purpose when it specifically came to a suicide death. The comment was often that I spent more time explaining what I did than getting the help that I needed. Whereas peer support and chaplaincy had the advantage of not needing to explain what you did as a role and what it meant to you to have lost someone who did the same role as you to suicide. You had the option to just talk about the things that you really needed to talk about. We also heard a lot about this separation between personal consequences and workforce ripples. So the personal consequences was how the individuals actually felt following the death. They had a feeling of anger, which was very loud throughout the course of the findings, both a sense of anger at themselves at times, feeling like it was their job to know when someone was in a place of harm and intervene, but also a sense of anger at the organisation when they felt like there might have been steps that could have been taken that weren't. We also saw that then there was this workforce ripple effect, people commenting on either changing their role or leaving their role because of the response or reaction that they saw to the suicide death. So that sense that it was both a personal toll, but did also have operational and organizational impacts. We did hear a lot about these being examples of potential psychological harm or psychological hazards as they're defined under the Australian Work Health and Safety legislation. So we are going to be digging into that a little bit more as we continue to analyse the data. So coming out of this first round of analysis, we have some key takeaways and some actionable recommendations for organisations and leaders to be able to implement. So we know that postvention is a really critical component of that suicide prevention pathway and of broader organisational health. A lot of the time people felt like they didn't need a postvention response until they needed to take action following a suicide death. And then there was a sense of, and now we don't know what to do. So one of the first things that we recommend coming out of this is to implement a formal, proactive postvention framework. Many organisations are in the process of or already have a suicide prevention framework, but what we found throughout the course of our conversations and working with various organisations around the country is the postvention component of that framework is not well fleshed out. It will often say to initiate postvention responses like the EAP, but beyond that, there's not a lot of consideration for some of those step-by-step actions that need to happen about what are the ways that you can manage operational demands while still caring for the people who you need to care for. So as part of creating these frameworks, we recommend sort of 3 key points. Have a break glass guide, so a clear step-by-step process for leaders at all levels that outline responsibilities. So what are you responsible for and who might be the people who could action that responsibility? This helps remove ambiguity and helps provide like a consistent standard of response. It was also recommended that there's a proactive reach in of support. A lot of what we heard is an expectation of if you're struggling, reach out. But what people wanted was organisations to proactively reach in and make contact. This could look like trained peer support or welfare officers being on site at a workplace, or even, if appropriate, leaders themselves being available. It would be different depending on the situation and the organisation itself, but having that proactive reach in, that sense of acknowledgement is really important. Part of it was also hearing about a designated liaison officer, having someone who is the point of contact, someone that family can go to, someone that co-workers can go to help with what can sometimes be viewed as a bombardment of multiple disjointed calls during that initial shock phase, which then disappears sort of 3 to 6 months later when people feel like they genuinely do need support and are in a place where they can actually access support. Accompanying this framework, there was a need for leaders to have support to respond through both resourcing and training. So part of it is having access to the ability of the training to identify and support people who might need help. So being able to identify, okay, this person's behaviors have changed, they're going to need some additional support. Part of it is also some training to understand what are the policies and processes that might be impacted. How do I action a leave for someone to go and attend a funeral potentially interstate? What are the return to work procedures for someone who's been affected by this? Part of it is also understanding that leaders in first responder agencies are not robots. They are also human beings who are going to be impacted potentially by the death of one of their team. So it's also about leaders having an understanding about their own well-being and being able to model some of that emotionally intelligent leadership, or being able to identify and acknowledge that that's not something that they feel is their skill set, and being able to put someone else in a position where they can model some of that, that sort of healthy leading with empathy. There's a need to deliver mental health support that's tailored to service culture. We understand that emergency services are a unique cultural group. It is a group that has its own language, its own norms, its own behaviors that are accepted within those groups, and that impacts the way that they perceive a suicide death. A lot of the time, first responders are acutely aware of the circumstances that surround a suicide death, and there's a heightened sense of that I'm required to act. I need to understand what's happening. So having a mental health support service which is more tailored to those service cultures are going to be able to respond better to how a first responder might be reacting or experiencing the suicide death of a colleague. So steps that can be taken to make this happen is to establish external vetted support networks. We heard a lot from people who said they wanted people to access support that was culturally informed, but not internal to their organization. So they felt like it had more guaranteed confidentiality. It was something that they wanted peers to potentially be involved in, but retired peers were seen as a valuable source to be able to be external, but still in the know. Part of this was also having consistent data collection to be able to record and report on retention, absences, well-being outcomes, and organizational trust, to be able to see how influenced the staff are from a suicide death. And then finally, as you were moving through those first 3 steps, coming back to the core of why you want those steps to happen. And that's prioritizing people over process in the aftermath. I know that can seem a little bit contradictory when I said at the beginning of this to implement a framework, but a framework is a guidance system. It's meant to help make decisions in high pressure situations. But you don't want that to become a checkbox or a tick and flick where people go, but I did everything I was supposed to do according to the framework, without taking into consideration what the individuals actually needed. So part of that was about reviewing the administrative processes. So are they going to help with managing personal effects? When should a job ad go up to replace a staff member? What does internal communication look like? Part of it is around understanding appropriate leave circumstances, and that some individuals might want to be in the workforce, some may need to step away. And how do you accommodate for that within a policy setup? And then also about meaningful memorialization. There isn't a one size fits all approach. For some, it's going to be very specific to that group. For others, it might be a full, appropriate funeral. But all of that needs to be consulted with family and colleagues. In the framework, you should have steps built in that allow for prioritizing people over process. So rather than dictating what a decision is, it should dictate when a decision should be made and let the circumstances guide what the decision is. And all of this will help with taking these actions will help with actually ensuring protection of the most valuable asset that first responder agencies have, and that are its people. Moving on from this piece of work, we've been working in the postvention space since 2022 when we first put together the National Lived Experience Advisory Committee. Since then, we've been moving through both military and first responder spaces, working in the postvention area. And so we have on the screen some QR codes that you can go to look at some of the other products to come out of this work. But you'll also find a QR code for the executive summary and short report of the priority actions that we just outlined here in this briefing. But we've also got a lot more work coming that will be happening through 2026. We have some work with standby support after suicide, looking at what is the impact on a police officer when delivering a death notification that is a suicide death notification. We are going to be developing specific postvention resources and workplace toolkits with standby support after suicide for each of the first responder agencies. We are looking at a national action plan for a coordinated response network across states and territories, similar to the work that we did with Defence and Veteran Networks. And then we're also going to be reopening data collection to help expand the data that we have to collect more from families and the service providers who support the co-workers and the families. We only had, I think, about 6 family members respond at the initial data collection phase, and so we want to go back out and collect more from the families themselves. We will still allow co-workers to continue providing us with additional information, but we're going to reopen our data collection in 2026 with the hopes of expanding what we know and providing more specific support and knowledge to the family members. We've been working closely with a number of organisations to support them in planning the translation of these findings into practical policy frameworks and implementation strategies. So if that's something that you'd like to discuss, you're more than welcome to reach out to discuss it with us. But from here, we're now done with our presentation. This is just some references for you to look at. But I'm going to stop sharing. I encourage you now, if anyone has any questions, to use the Q&A function to the side or raise your hand. Oh, this. No, hand went away. This is very similar to when I used to lecture at the universities, I must say. Okay. Well, if there aren't any questions, I will bring us to a close shortly. Following this briefing, we will be sending out a copy of the short report if you didn't have time to see that. Oh, hang on, there's some questions. Oh, they're going in the chat. Let me see what's happening in the chat. So Ginny said, thought it was a very accurate findings. Thank you. Thank you, Ginny. And then Michael said, are there any international models for postvention support frameworks? There have been a number of international sort of pieces of work that have been done looking at postvention support frameworks. Some have been not within the first responder communities. There has been some done from the Samaritans, I believe it is, in the UK, done with paramedics. And then there was one done by the International Fire Council, I think it is, based in New York. However, both of those pieces of work were based on civilian postvention frameworks. They weren't based on international models for first responders. So there was always a piece of those models that were put forward that we were hearing that weren't quite fit for purpose. They were more designed for civilians and then reskinned for first responders without considering specifically the needs of the first responder organizations. So that's where our curiosity really came from, is what do the first responders themselves think that they need? And then I have a very kind voice. Thank you. Thank you, Miranda, as well. And we're hopeful that the practical recommendations will mean that emergency services organisations will be able to implement the recommendations as well. We've already been in conversation with a couple of different organisations about the best way to make it fit within existing policies. So we're very happy to continue those conversations with anyone who might want to have those conversations. I'll just check that there's nothing that's ended up in the Q&A as well. Oh, yes. I see a comment here from Nick. Better workforce planning right from recruit school is critically important. Some people struggle with the work required in first responder world more than others. I do think that, yes, recruit school is an excellent opportunity to begin introducing some of these concepts. We heard a lot, and I think I may have briefly mentioned this, but we heard a lot from people who talked about the fact that they didn't know that they needed to understand the processes and the rationale behind postvention until they were responding to a suicide death. They didn't recognize that it was going to impact their teams or their communities differently. So being able to build in not just postvention, but a lot of mental health structures in those early stages of recruit school and then reinforcing them throughout the course of someone's career is going to set up a better response. I've said a couple of times in other circumstances, the best postvention responses start long before a suicide death happens. So recruit school would be a place where you could introduce some of this to help identify who are the best people to be responding and when. Did the study consider many ex-defence personnel? Now, that's a great question. We did get a number of former serving defence who were part of this study. They did comment that they at least had their white card, was often sort of the response, was that they were able to access supports because they were able to use the resources given to them through their defence background. I found that really interesting because there's often a perception that ex-serving defence don't have access to any resources. But when we spoke to ex-serving defence who then became first responders, which, by the way, is about 10% of our first responders, except Tasmania, where it's closer to 20%, there is that perception that veterans don't have a lot of access to support. But when we were speaking to them in the context of this study, they felt like they had much more support than their peers. Oh, and we do have a hand up. And I think I might be able to give you the option to unmute your mic if you'd like to ask a question.
Thank you. Yeah, my name's Lee from United Firefighters Union. Amongst firefighters, police, correctional officers, A couple of years ago, we done a bit of a study of our various membership across 3 different unions, and it showed on average about 32% of those the current workforce at that time were ex-defence, and just what you said then in regards to they had access to their because of their military service, other support networks, even post after someone committed suicide. But they was more reticent, I guess, because of trying to stay away from trauma on top of trauma, to pull back away from situations, I guess, not get themselves into situations, I should say, where a colleague or whatever may have passed away. So it's interesting.
And I think it's one of those things that we don't understand super well in terms of how many of our first responders are former serving military. The kind of numbers that we were running off came from the census, so people who indicated they were former serving defence and then were currently a first responder. That's where our sort of percentages came from. So it didn't count former serving first responders. So it's possible those numbers are much higher. But I think for our study, the people we spoke to, they did say they had access to something which they felt like their peers didn't necessarily have access to. And I think that also partially answers your question as well, Anna, from the chat, which was whether or not they actually had more support is not really up for question, but it was, did they feel they had, or they perceived they had more support? Yes, they perceived they had access to something that their peers didn't have. So that's probably the kind of key difference. And then I'm just going to take one step back to Michael. Was there any focus on the subsequent impact on first responder colleagues who are involved in organisational reviews of the death? Yes, we have not fully unpacked that section of the data, but there was certainly a lot of commentary around coronial inquests and investigative processes and how people felt about those, and that was a piece that they felt was ill prepared for. The idea that 2 or 3 years later is when some of these reviews may have been happening, and that's when they really needed support, and that's what they were really seeking at that time. And then Chantel, less stigma attached to accessing those services provided by the DVA white card. That's certainly a possibility. We're hoping when we go back out for our next round of data collection, we may be able to investigate some of these things a little bit more as well. But also for this particular release, we're doing our sort of highest level of analysis. What we were interested in with this particular analysis was, what can we give organizations right now? When we started this study just over 18 months ago, the planning started. Actually, I think it was longer than that. But the planning of this study, one of the first things we wanted to get out of it was practical support for the organizations to be able to respond at the moment when they needed to respond. That's what we were hearing people needed. One of the big things we heard throughout the course of this study and other conversations is there are no leaders that want to do a bad job. Nobody wanted to respond poorly to their teams. But often when the suicide death occurred, they were left kind of scrambling, feeling like, I need to respond, but I'm not entirely sure what and how I need to respond to meet my legal obligations, to be operationally still fit, to be able to have, trucks on the road, while also making sure that all my people are taken care of. They were lacking a bit of guidance on how to do that. So the priority with this first round of analysis was to offer as much guidance to answer those questions, to give leadership and organizations the tools to be set up in the event of a suicide. So some of the questions around that idea of maybe there was a less stigma around the former serving defence being able to use the white card, we haven't had a chance to dig into yet, but it's certainly something we're interested in looking at, and we'll also be looking at in our next rounds of data collection as well. I'll quickly check back with the Q&A and make sure I'm not ignoring anyone there. Okay. Is there any other questions for anyone coming out of the release of the first round of the SAFeRS findings? Okay. Well, in that case, I will give everyone a bit of an early minute, and I will say thank you so much for taking the time to come along today and join us as part of receiving these findings. You will be receiving a follow-up email with a link to both the recording and a link to the short report, the executive summary, and there is a key fact sheet as well. For anyone who would like to stay involved as we continue the analysis of these findings, but also reopen the data collection for additional voices to be heard, I encourage you to reach out and be in contact. So we will be emailing you all, and you're more than welcome to just reply to that email, or my contact details will be in the reports that you're welcome to reach out through that or through our research at MESHA channels. And then we'll be able to connect you in with the best, most appropriate team member to have more of a chat with you. But thank you so much for your time today. I really appreciate you taking the time to sit in, but also for your interest in this area. By being able to come together as a community, we'll be able to better serve our first responders and ensure that they have all of the resources and tools they need to keep us safe. So thank you so much, and I hope that you enjoy the rest of your day.